Bill, thank you for the warm welcome. And once again, thanks to the Michael Reese Research and Education Foundation for all the work that you do all the time, but especially for sponsoring this very important topic. So as I reflect on the last year, I hope that many of you will agree with me that we've seen heroes rise to the occasion. We've seen our healthcare system, like our country, being pushed to its limits. And we have felt, I strongly believe, with much more left to be revealed and much more left to be learned from, the profound impact on the COVID-19 pandemic on every aspect of our personal and professional lives. Now pushed to the brink, we find ourselves at a crossroads. The situation demands that our healthcare system, like our country, choose a new direction. It demands a system that is more representative and inclusive, whether it's from the State House to the boardroom, to the operating room, to the exam room. It really has to take a different direction at every level. It also demands a system that offers equitable access to care delivered by a team of providers who are able to respond to the patient's needs within the context of their community and coordinated by a team of professionals to help guide that patient on a path to better health. The situation demands, in short, an integrated system of care. It always has, but especially now. Our experience over the course of the past 9 months has revealed many things, including these two things. One, a new high-risk population of patients with underlying conditions who are particularly susceptible to contracting the coronavirus, and if so, are most likely to experience a difficult experience. And the increasing demand for mental health and substance abuse treatment services. So I hope that these two lenses will set up the conversation we're about to have and serve as a framework or examples in the first part of our discussion about the integrated care model. And in the broader context, the role of an integrated care model in the ongoing management of COVID-19 in our most vulnerable communities, affecting our most vulnerable populations. I'm pleased to be joined by the two individuals that Bill has introduced, each of whom is a recognized leader in the study, implementation, and impact of integrated care. I'm happy to welcome each of them to our conference today, and I am pleased to welcome our viewers and visitors. So with that, allow me to ask Dr. Doriane Miller to start with her presentation.
Great, thank you so much, Mr. Garza. I'm going to address the comments that around the issue of the importance of integrated care in the COVID-19 environment in the area of mental health. During the introduction, I was introduced as an associate professor of medicine. I'm actually a primary care doctor, a general internist, and spent most of my working life in under-resourced communities, both in the Chicago area as well as elsewhere, and also been involved in doing program design in the area of primary care mental health integration. Currently, I'm working with a group here called ECHO Chicago, which stands for Extension and Community Health Outcomes, and I've been heading up our integrated care and mental health for a number of federally qualified health centers and community health centers within the Chicago area in the areas of both serious mental illness as well as behavioral health integration through collaborative care. Now, oftentimes when we think about the issues of integration as scientists, as healthcare providers, we think about things from a population database, but there's something that I don't want us to forget. And so these next couple of slides, I think, will help to bring some of this home. Next slide, please. A collage of photos of the impact of COVID-19 on members of our community. As we think about both the briefings that we have received from the mayor around how we need to engage in terms of flattening the curve, whether it be from going into grocery stores and big box stores and seeing empty shelves of supplies, when we think about going for a walk as a young family with our child and having to mask up, and then also the incredible grief that so many communities have experienced around not being able to grieve for their loved ones in the way that they would normally do in terms of group gatherings at a funeral home or at a church. I think that all of these things make an incredibly difficult impact on the way in which we are accustomed to functioning as a society. In June, one of my clinic patients passed away, and I decided to go to the wake for that patient and literally stood in line with other family members and friends in order to go in to express my condolences and to view the body. Everyone was masked up, but because of the overwhelming grief that people were feeling, there were also lots of hugs that were going on at that time. And so the question of how we accommodate the impact of this in the long term, I think really extends itself into the human toll of what we're experiencing. Next slide, please. In addition to that, we also have been witnessing the incredible civil uprisings that have been a result of not only the murder of George Floyd, but also other murders that have taken place and have been brought forward through the media over the past several months. Sadly, there is a list of long names that are there, but as I think about the people who have been impacted by Black and Brown communities, this is another level of trauma that is impacting the mental health of the people that I care for as a primary care doctor, and as many of you care for, whether you be health administrators, psychologists, or for people who are looking at this at the population level, many of our scientists and health services researchers that we have on today's call. Next slide, please. And so what do we have here in terms of thinking about the impact of this? I put the photo in of a dripping faucet at the top in order to think about some of the baseline issues that people are coping with in their day-to-day lives. So as we think about the impact of mental health and the issues of COVID and integration, I oftentimes think about what types of things have impacted our communities from the perspective of the social determinants of health as serving as more of a baseline or a floor of why people come to us in the way that they do with their health concerns. And so water has sometimes seemed to be the most powerful force on earth. When we think about that dripping faucet, perhaps on a rock, we think about things slowly but surely wearing away the resolve and resilience of communities, whether it be poverty, whether it be transportation, food insecurity, et cetera, and all of those things that can impact one's physical health as well as mental health. Throw on top of that a hurricane, and so you can see the photo that's over in the lower left-hand side of your screen of a hurricane approaching the Florida Peninsula, and having that hurricane be COVID-19. However, as opposed to having this as just a short-term event and then the sequela from it, that is later followed by the tsunami that many communities have experienced in terms of the civil unrest and uprisings that we've seen as a result of the death of George Floyd and others. And because, as I said, we usually think of these as one-time, short, limited events, these are actually things that are ongoing. And so how do we think about accommodating the impact of these events along with the baseline events that so many people in our communities experience within the context of the delivery of primary care services? Next slide, please. So I'd like to make an argument for integrated care through primary care and mental health. This will be made from the perspective of demand and resources that exist, particularly for our mental health providers, whether they be psychiatrists or psychologists, but also from the perspective of cultural competence. The demand for subspecialty services really far outstrips the availability of these services and the resources, especially in our under-resourced communities. And so oftentimes patients have difficulty accessing subspecialists. There are also social and economic distance issues that reduce care availability. And in addition, by referring out into a community setting, oftentimes there's a loss of continuity of care for patients and providers. People have to leave their medical homes. They become very comfortable in the care that they have received in these medical homes with the group of providers that they've come to know over the years. And when they send them to see someone for something as sensitive and personal as mental health care, they sometimes don't go because they say, I know you. I know the kind of care and the quality of care that you provided for me in my primary care home, but I don't know these people that you're sending me to. And so how can I extend my trust that they will provide me with the same quality and level of care that's there? So again, those types of issues, in addition to just the day-to-day issues of how do I get there? Who's going to greet me when I get there? Transportation, other issues come into play. Next slide, please. However, I think that in terms of thinking about the reasons why that this is important, and particularly in the area of integrating care into primary care settings, a case example of serious mental illness in Illinois. About 5.4% of adults in Illinois have serious mental illness compared with 4% of the US general population. The shortfall of psychiatrists to meet the needs of people who have serious mental illness when they're referred by a primary care provider is anywhere from a 3 to a 10-month wait. In addition, there is a significant morbidity and mortality of patients who have serious mental illness due to chronic conditions such as heart disease, diabetes, obesity, chronic obstructive lung disease. And this patient population is less likely to receive preventive care. As I mentioned before, in terms of some of the issues around social determinants of health, there are high rates within this population of social vulnerability, high rates of homelessness, poverty, incarceration, and also social isolation. And then there are access barriers to quality care due to insurance. For those people who do have insurance, oftentimes it's Medicaid, and oftentimes the ability to access mental health services, whether it be for patients with serious mental illness or patients with depression and anxiety, are somewhat limited because of the patient's ability to have that insurance accepted by providers in the community. Next slide, please. The issues that I think that we're faced with are multiple. Cultural competence of the providers that are providing the care. The reason why I opened with the photographs that I did is that to acknowledge that in the time of COVID-19 and also this civil unrest that we're experiencing, that there is quite a bit of trauma that these communities have experienced. The issue of cost is also certainly a factor in terms of thinking about, is there a need to bring in other providers who can provide care for patients that have mental health challenges, and then thinking about ways in which you can do delivery system redesign and also redeploy resources within those settings in order to provide care. One of the things that we provide through the ECHO Chicago program is decision support and also suggestions for delivery system redesign for community health centers and federally qualified health centers so that they can look at what they have and in what ways in which they can help to uptrain their providers in order to provide this care. Tracking outcomes is also something that's very important. And so for those of you who are leaders in your institutions, whether it be through insurance, HMOs, and others, you want to make sure that any of the changes that are implemented in your systems are actually tracking improvements in care and specifically treatment to target. And so being able to generate those mechanisms on how you are able to track them at a population level is very important. And then patient and community engagement, looking at whether or not there needs to be participation advice from the patient population that you're serving to see if they would be interested in receiving more of these services in a carve-in versus carve-out model. I'm sure that there are other issues that will come up, perhaps as questions in the discussion a little bit later, but I wanted to tee these issues up for us today as we think about ways in which we can address mental health integration into primary care settings in our communities. Thank you again for the opportunity to make these comments, and I look forward to our discussion a little bit later.
Dr. Miller, thank you for a very informative and important presentation, and we will circle back in a few minutes. At this point, I want to introduce Dr. Rahmandar, who once again is with Lurie Children's Hospital. Dr. Rahmandar.
Hi, everyone. Thank you so much for having me. I am Mariah Rahmandar, tough name, and I am going to be talking about adolescent substance use and co-occurring mental illness and the importance of integrated care to battle both of these issues. I really appreciate Dr. Miller's context of the racial inequities that are going on and how this health crisis that we're experiencing with COVID is exacerbating those. Next slide, please. So by the end of this session, I hope that we'll be able to discuss recent trends in adolescent substance use, articulate the importance of integrated care in adolescent substance use treatment, and also just give you guys some information on how to refer to our program if you have patients or family members of patients or people you're interacting with in the community who may benefit from our program. Next slide. So just to set the scene, this slide is showing the most common substances used among high school students. And this is freshmen through seniors. You can see that dark blue line is the percentage of students who reported ever using these substances, and the light blue line above it is the percentage of students who reported current use, so meaning past 30-day use. And this is in our state, in Illinois. So the most common substances are alcohol, with just over half of students reporting ever trying using alcohol, and around just under a third reporting currently using in the past 30 days. E-cigarettes is next with just around half reporting use and around 20% reporting currently using. Marijuana comes after that with just over a third, and again, around 20% reporting current use. And then cigarettes, and this has continued to go down over time. Next slide, please. And really the health crisis that we're experiencing right now has increased overdose deaths related to opioids in particular, and some other substances. And in Chicago in particular, this is disproportionately impacting Black people, especially Black males, compared to other populations. And next. And we are seeing a mental health crisis increasing among our teens who really everybody's life has been turned upside down, and this really important developmental stage is really being turned on its head with everything changing in their lives. Next slide. So there's a giant treatment gap in our community, and I mean in our country and probably the world, and we see this in adults, but even more so in teenagers and young adults. So young adults are the age group with the highest need for substance use treatment. Around 16% of 18 to 25-year-olds meet criteria for a DSM, the DSM criteria for a substance use disorder, and that's around 5% for 12 to 17-year-olds. And then few who need treatment actually receive treatment in a specialty facility. So that's around 6% of 12 to 17-year-olds and 8% of 18 to 25-year-olds who have a substance use disorder receive treatment in a specialty facility. And it's rare for adolescents and young adults to perceive a need for treatment. And I think everybody is aware of that. So only 1% of teens and 3% of young adults who met criteria for a substance use disorder, but were not in treatment, felt that they needed treatment. So this brings up the importance of interventions that can increase motivation to engage in treatment, and also the importance of considering treatment outside of specialty facilities in a primary care setting and other outpatient settings to increase access to care and break down some barriers. All right, next slide. And so here's a traditional model of care for substance use and mental health conditions where you have these different levels. So early intervention, so really kind of meeting people before, well, I'd say prevention is even in front of that. And then you have early intervention. So trying to tackle this issue when somebody's just started trying some things, dabbling before they've really met criteria for a substance use disorder. Then there's outpatient treatment. And that really traditionally is seen for people who aren't engaged, in like moderate to severe substance use. But I'd like to argue that that's kind of an old-timey way to think of treatment. And then you have the higher levels of care, so intensive outpatient, so a couple hours a week, a couple times a week, partial hospitalization, a couple hours a day, most days a week, but sleeping at home and going home on weekends. And then you have residential and inpatient. And then there's aftercare, which may be the most important level of care. But like Dr. Miller brought up, behavioral and mental health wait times are out of control. There are very few adolescent specific treatment programs for substance use and even for mental health. But thinking of primary care settings where they can provide these things, the levels of care that I bolded, so prevention that I didn't have on there, but early intervention, outpatient, and aftercare services are really just like tailored for somebody who knows this patient, who can see them over time. And this is really important since substance use disorders are often considered chronic diseases where recurrences are common and really can benefit from long-term follow-up. And these may not always be chronic issues for teenagers. Luckily, most teenagers are resilient, and people who use substances often don't end up having a problem. But this can be monitored over time to intervene when it looks like somebody is developing a problem and help people manage that long-term. Next slide, please. So treatment for mental health and substance use disorders often occur in different silos and is really, of course, undertreated. So in our state, I just wanted to point out that minors can consent to substance use treatment under Illinois law. However, family involvement can be beneficial and improve outcomes and improve, follow-up and engagement and really kind of setting up a healthy environment for recovery in their home, as well as, helping family members who may need mental health or substance use treatment engage in care as well. So motivational enhancement therapy and cognitive behavioral therapy have been shown to be effective, as well as I just wanted to mention that there's some ways to increase this. We see that a lot of teens are not interested in engaging in care, but we have some techniques that can help people increase their motivation. So whether that's, motivational interviewing to increase the internal motivations to engage in care, but also providing external motivations in terms of prizes or gift cards for engaging in care, and seeing some reimbursement would be great for those to not have to get the money for those from other sources. So really co-occurring mental health issues is really the rule as opposed to the exception for teenagers who have substance use disorders. So really it's ideal to not have to say, oh, what's primary, where should you go, but really being able to kind of handle those both in the same setting and work together as a team. And so in having a substance use disorder during the teen years increases the risk, if you don't have one already, of having a mental health issue as an adult, and increases suicidality rates as well. Next slide. So just really quickly, wanted to let you guys know about our substance use and prevention program at Lurie Children. So we are off-site from the main hospital. We're in the New City area of Lincoln Park, right by the North and Clybourne Red Line stop, and off 94 at the North Avenue exit. So we are not a freestanding substance use treatment program. We are really embedded within adolescent medicine. So that can kind of decrease the barrier for a teenager to be like, I don't need treatment. I'm not going to some treatment facility. This is in an outpatient setting, going through the same doors as people who are getting their checkups, getting their, vaccines, getting STD checked, birth control, everything like that. Gender care, same building, same waiting room. And that's our team. We have our administrative professionals, psychologists, who have background in trauma, our LCSW, who does the bulk of the therapy as well, a social worker who reaches out to patients, do some case management between visits, as well as a nurse practitioner, who's the other medical provider who does work with me. All right, next slide. So if anybody wants to refer to our program, calling 1-800-KIDS-DOC, and that's our website. And that's the same way you refer to any program at Lurie. So hopefully that's easy to remember. For people who need help outside of, who may not be interested in our program or kind of outside of people we would see, our age group, I can call the Illinois Helpline for Opioids and Other Substances, and they'll match people with treatment providers based on insurance and location in the state. Considering prescribing buprenorphine, it's really easy, really rewarding, and they're free training and other education at pcssnow.org. Encouraging people to access naloxone who are around people who could experience an opioid overdose. And then here are some parent resources really geared towards teens, specific to COVID, but also just substance use in general at this American Academy of Pediatric websites there. And I'm looking forward to answering questions and discussing more.
Thank you. Really appreciate the reference research material as well. So let me ask the two of you a question that I think is probably on a lot of people's minds, and that's, what have we learned about the value of virtual integration over the course of the pandemic? Dr. Miller, would you like to open?
The issue of virtual integration over the course of the pandemic. And when you say virtual, you're referring to virtual visits?
Telehealth, right? The expansion of telehealth, right?
Exactly. For me, it has been a mixed blessing. And I'll start with some of the positives, and then I'll end with some of the challenges. To be able to have a lens into where my patients live and to do a virtual house call, if you will, is something that I found is a real benefit in being able to do virtual visits, as well as continuing to literally see my patients, I think has been a real benefit. However, one of the things that it's uncovered for many of my patients is the issue of having a digital divide around access to the technologies that's necessary in order to be able to see them. I'm a primary care internal medicine doctor. I care for a number of people who are older, and the way that some of them have been able to work around this is to have the engagement of younger family members to get them onto a call, whether it be a built-in video visit in my electronic health record platform or onto Zoom or Doximity in order to be able to see them. And sometimes it works and sometimes it doesn't, but I think that it's been much more revealing that we have so many people who are living in communities within the city of Chicago for whom that there's a real digital divide. If we're going to continue to expand virtual visits, and telehealth, I think being able to address the widespread use of digital platforms for communities that are under-resourced is something that's critical in order to make that work in the future.
Great, thank you. And Mariah, what's your experience been like?
I think really similar to Dr. Miller's, where I think this has really been a great advancement in increasing access and kind of the ways in which people can access care. This has been wonderful for my patients who have gone off to college or some other, training away from their home to be able to check in and do visits virtually and not just have to say, okay, I'll see you if you come home for the holidays. But it has really continued to broaden the chasm between, the socioeconomic disparities and where people do not have, access to internet at home. And, we don't get reimbursed for telephone visits. We still check in that way because it's important and we don't want our patients to have no care. But the reimbursement structure really needs to change to meet the needs of patients, in addition to really helping get technology more broadly into communities that need it the most.
Well, I appreciate what you just said about the reimbursement structure. So I'm going to stay on that point and ask, maybe from a managed care perspective or an insurance provider perspective, do we need to change how we view or even stratify patients based on the risk of contracting COVID-19? Mariah, let's go with you since you brought up that point.
I deal with, I mean, certainly I see a younger age group. So I see I don't really see the young kids in my house. I have the young kids who are low risk for contracting and spreading, but I see the population of people that are currently responsible for acquiring COVID right now and spreading it. And so I'm not seeing the communities who are dying from it. So I will defer to Dr. Miller to talk more about
Right.
that. But what I think we need to really we can't rely on an executive order long term. But this health emergency has yeah, I think has done a wonderful overhauling of how we can provide care. But we need to see long-term changes in being able to continue to connect via telemedicine, considering telephone visits, as well as valuing the other, providers on our team. So our social workers who, mostly go unreimbursed in their work, we have to, support in other means. That is so important for case management and check-ins, and also in order to provide truly integrated care. So where it's not like I'm in my office, the patient sees me, and then we switch places, and they go down and see the behavioral health person, or they call into their therapy visit. We could work together and be in the same room together and be, paid for work we're doing, where the patient doesn't have to repeat themselves, and we can really work as a team and talk as a team with the family and the patient and the other providers. That would be really important to really promoting integrated care.
Yes, I agree. Doriane, what do you think about that?
Thank you so much, Raul. I think that the kind of risk stratification that you speak about and figuring out ways in which there can be better reimbursement for care coordination under these types of models is absolutely critical. I was on a call yesterday with a number of my community partners who were discussing the issue of how in many settings, youth are concerned about going out and bringing COVID-19 to their older relatives who have chronic health conditions because they're having difficulty getting something as simple as being able to afford to have a mask or a face covering. And so the question of figuring out ways in which we can provide adequate care coordination at a distance so that we can serve the needs of the populations who are at higher risk for COVID-19, absolutely critical. One of the things that we have seen both in our African American as well as Latinx communities, because of multi-generational living and because of people living in more crowded conditions, is that there's been much more spread of the virus for people who live in those settings. And again, those are the people who, unfortunately, when they become sick, because of their underlying health conditions, they end up having much more complicated courses, including hospitalizations and sometimes deaths. So I absolutely agree. We need to do a little bit more risk stratification based on the population and their risk factors.
Great. Thank you. Well, I think we've got a few more minutes because we had an extended break there. So I just have one more question because I don't see anything in the chat room. However, as far as the question goes, I do see a lot of positive contents about your presentations, both being relevant and important at this time. So let me ask you this last question. As a healthcare system that includes the Illinois Department of Healthcare and Family Services, the managed care providers, providers like the University of Chicago, Lurie Children's, Access, Aunt Martha's, etc., how do we use the experience we're in right now as an opportunity to really intentionally ensure that there's more of an integrated approach to care? I often say within our organization, many of us in the community are touching the same patients. However, we're not necessarily talking to each other about what's happening in that patient's treatment, regardless of what role we play in the cycle of care. So how can we take this experience and treat it as an opportunity to ensure that we're all more integrated as a network?
Population health improvement is team play. And whether we're talking about a academic health center, a community hospital, home health care agencies, substance use providers, mental health providers, having a background platform where there can be an exchange of information around the patients that we are serving as a community, I think is absolutely critical. We're facing the closure of one of our hospitals here on the south side within the upcoming year, Mercy Hospital and Medical Center, which is actually the oldest hospital in the city of Chicago. Many of you may not realize that, but was started back in the 1840s. And it's going to have a tremendous impact on the ability to provide care for people who live in the Mid-South side. That particular institution not only provided care, but also in the area of cultural competence. And so thinking about people whose first language is not English, whether it be people from the Chinatown Armour Square community, from the near West Side for whom people may speak Spanish. And so the question of thinking about how we can think about this as a network and the kinds of services that are needing and having people to talk to one another about those services, I think is absolutely critical. I think that the generation of an information technology platform may be a step in the right direction in terms of providing that type of infrastructure, but also opportunities for person to person, institution to institution care and coordination of services will help to fill this gap.
Thank you, Maria.
I don't have too much to add onto what Dr. Miller said, but yeah, I think that technology is really going to be where it's at because, you know, the hospitals have the infrastructure to deal with technology, and I think community programs have a variety of ways. But you know, I think I'm hoping that we're going the way of no longer having conference calls, but that we're connecting, you know, even face to face over Zoom. It makes a huge difference, I think, in connecting, you know, people far away. So whether that's community groups with medical and behavioral health providers. And so, you know, I'm hoping that we keep, you know, collecting releases of information and connecting with our social workers and connecting with community groups so that we can all take care of, you know, people together, because so little of the work that keeps people healthy happens within like the walls of my clinic. I mean, it really takes the, you know, the world outside to promote health and wellness. So.
Thank you. Thank you to both of you, Dr. Doriane Miller and Dr. Mariah Rahmandar. Really appreciate you pulling yourself away from critical work, seeing patients and working with our communities. And we're very fortunate to have had you participate today. Two world-class physicians serving and leading world-class healthcare institutions right here in Chicago. Thanks for making this a rich dialogue and for really imparting a lot of great knowledge about what is really happening and what works. So thank you. At this point, I'll turn it back over to my esteemed colleague, Dr. Cheryl Whitaker, to take us to the next phase. Thank you, everyone.